Welcome back, everyone. We are very fortunate to have this incredible panel of NET experts join us from across the country here today. And all of our speakers are deeply committed to the NET community and are active in NET organizations, NET research, and of course, they all see NET patients. It's an honor to introduce again our speakers for today in order of appearance from today's conference. Dr. Kalicia Clark, surgical oncologist from Medical College of Wisconsin, Dr. Sandy Kataya, and Dr. Nina Vijay Verghia from Fox Chase Cancer Center in Philadelphia. Dr. Osman Ahmed from the University of Chicago, Dr. Tom Hope, radiologist and nuclear medicine from UCSF, and Dr. Julie Halley from Sunnybrook Health Sciences in Toronto, as well as Josh Mailman, my co-moderator for today's live Q&A. And again, this is just a reminder that our programs are intended for educational purposes only and do not substitute for medical advice. We encourage you to talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions only, and they do not represent the opinion of LACNETS. So with that, we're going to get started with questions, as we have many. Let's start with this really important question, and I'll start with you, Dr. Clark. What is the priority for treatment? Is it cell differentiation or tumor grade? And I know that you may consider this with surgery.
That's a tough question. Probably both would be my answer. I definitely think so. Poorly differentiated tumors, more commonly called NECs, I think are much more aggressive, and even with aggressive surgery, the outcomes are not as great as we need them to be. And so in those patients, almost always I encourage systemic treatment first up front, and then carefully select patients that I would proceed with surgery. So I guess from that standpoint, then differentiation. And then in the well-differentiated patients, then I really pay attention to grade. Sometimes we'll use a neoadjuvant approach for patients with either grade 2 or certainly with grade 3 disease that have high volume disease, even if they're surgical candidates, just to make sure that one, we give them the best chance of removing all of their visible disease, which means giving them an R0 resection before we do surgery. So I would say both, but grade definitely, as well as differentiation, are both important.
Dr. Vijay, do you have anything else to add to that?
No, I think that's, they're basically, they go, for the most part, go hand in hand. More higher grades are more poorly differentiated. The lower grades are mostly well differentiated. And, we take them both in conjunction, because sometimes what happens is grading can be a little patchy, and which means some part of the tumors are slightly higher grade, the others may not be. Differentiation. So if you have both, in my practice, if I have a patient who's it says that the KI67 is only 26% or 20%, but the morphology is poorly differentiated. So I actually take the one that's higher, like usually, assume the worst and then treat it accordingly. So they're both very important and really affect our treatment paradigm significantly.
Thank you for that. And some of you, well, I think all of us have been following the news, and this new drug, dostarlimab, has been coming up a lot in the news. So Dr. Vijay, can the new and exciting med dostarlimab be used at all for neuroendocrine tumors?
So dostarlimab is just a new PD-1 inhibitor. So it's like a drug which is similar to Keytruda or Opdivo that you guys know about. Like there's a lot of press around those drugs. And in that early study in a special kind of rectal cancer called the MSI high rectal cancer, there were great responses seen. Unfortunately, these drugs, PD-1 inhibitors or PD-L1 inhibitors, this class of drugs has been tried in neuroendocrine tumors, like in different way, shape, or form. And so far, they've not resulted the benefits we want them to give us. It's only in the poorly differentiated tumors, so the aggressive high-grade neuroendocrine carcinomas. Sometimes there are some combination immunotherapies that are, have some signal of benefit. But other than that, for the most part, they're not that effective. And I do have to say a small group, literally, I actually did this part of research for a paper once, and there's in colorectal high-grade neuroendocrine carcinomas, the incidence of having this MSI high phenotype, so this special type of cancer called the MSI high, is up to like 8 or 9%, which is a good number. So it's a very, only the colorectal warts of the high-grade aggressive cancers of the neuroendocrine have this phenotype and they may benefit from these immunotherapeutic approaches. But for the most part, unfortunately, it's not something that's going to have benefit in our case.
Yeah, thank you for that. Dr. Kataya, I mean, there's a lot of oral medications out, and this person said, I read an article recently saying everolimus is only 30% effective in studies. So why is it still being used?
I mean, that sounds like, so, I always tell patients that it's indicated for slow-growing neuroendocrine tumors, essentially. And so, it's really hard to shrink slow-growing cancers, and because they don't really grow fast enough for whatever medication like chemotherapy or drugs to really shrink them down. From the RADIANT trials that were done, the effectiveness, the stability rate of everolimus is close to 80%. And the shrinkage rate is about 1% to 2%. But to me, it's much better than 30%. And it still remains a drug that we use quite a bit to keep things from getting worse.
Thank you for that. And a follow-up question, my doctor is offering the options of everolimus or PRRT, saying their efficacy is about the same. So I'm wondering for you, Dr. Kadaya, followed by Dr. Vijay, what your opinion might be on that.
I don't really think that they're the same necessarily. There's about a 20% chance that the tumors will shrink on PRRT and about a 40 to 60% chance of stability. And they're given very differently and they have very different side effects. Sometimes I have to reduce the dose to get people to tolerate it. I mean, my preference is to give PRRT in the sense because it's 4 doses. As long as the patient has good kidney function, they tolerate pretty well. There's not a lot of side effects. You do have to watch the blood counts on that treatment. And then at the end of 8 months, I have patients who are like 4 years out and still in remission from PRRT. And it's always nice to see that, not everybody has that great of a response, but there are some people who can't get PRRT because they don't have great renal function, their blood counts are low. So then I say everolimus is a good drug, that's also a good option. So I don't think you're trying to burn your bridges. I think you're just sequencing and you're trying to get as much of everything. You're not really sure which one's going to work. You just want to take something that will work and that you'll tolerate. So, just think of it as what am I doing now, but I'm still going to have that option later.
Thank you. Dr. Vijay, do you have anything to add to that?
Yeah, I as Dr. Kataya said, right, I think we do not know if one is better than the other. Dr. Hope actually has a study ongoing for lung neuroendocrine tumors where they're comparing everolimus to PRRT. So the question you want to ask is being answered in prospective study. So we will know at some point, but at least from the data we have right now, as Dr. Kataya mentioned, this is a marathon and not a sprint, right? You will go through all these treatment options at one point or the other during your treatment. You just choose the one that fits everything, fits your physical condition, where you are. Like I have patients who live 5 hours away, they cannot travel for PRRT. So they end up getting everolimus first. And when that's not possible, then they come for PRRT to me. I think, I also prefer PRRT first if the patient's eligible and, that same, just because of the same reasons that Dr. Kataya mentioned.
Thank you for that. Dr. Clark, there's several surgery questions. And one is, if a tumor is unresectable because it's too close to a blood vessel, what could make it resectable in the future? Would shrinking it make a difference?
So I think the first thing that I would ask is, making sure that you were actually evaluated by a surgeon with the expertise to truly tell you that a tumor is unresectable. I can't tell you how many patients I've seen who've been told they've been unresectable that actually have resectable disease. So I think that's point number one, making sure that you're seeing a surgeon that does high volume complex neuroendocrine tumors and really has the skill set to truly measure that. If a tumor is unresectable because of proximity to a blood vessel, it depends on the grade, the tumor grade and differentiation, what drugs we may initiate to try to help to downsize them. But as everybody mentioned, we don't typically get a lot of downsizing in a lot of the regimens. For example, for a grade 1 tumor, there's not a lot of options that are going to give you good shrinkage. A well-differentiated grade 1 tumor. For intermediate grade tumors, I've had good success with CAPE-TEM in a neoadjuvant setting to try to downsize, particularly in the pancreatic neuroendocrine setting. I've had good response there. For grade 3 tumors, again, there's not a lot of great options for downsizing. We have been exploring, I think more recently, PRRT in the neoadjuvant setting. We have not done that at our institution yet, but that's a study that we're actually drafting right now. And that's a complex discussion because the impact of radiation on the normal tissues around the tumor is really the biggest question. And how does that affect surgery? It's certainly feasible. I've done some surgeries after PRRT, but they're a little bit more complex. So we really have to weigh the risks and benefits of using that therapy up front and the complexity of the operation, and then if we use it neoadjuvantly. So I think it goes back to one, is it really truly unresectable? And then two, the grade really differentiates what treatment options we have at our disposal. But in general, it's hard to get these tumors to truly shrink. And so a good surgeon and team of surgeons who are comfortable in that vascular space and have the techniques to even sometimes do resections and reconstructions, I think is really important.
Really good points there. And this is an important question. Does removing the primary pancreatic tumor and regional lymph nodes significantly decrease distal metastasis, or do we not know? And I guess, also other types of NETs as well.
Right. So I feel like that's a little bit of a chicken or the egg question. So I think what I try to explain to my patients is that distant metastasis is often present at the time of diagnosis, even if you can't see it, right? So there's something called micrometastasis, which is where we have cells that are essentially floating around in the bloodstream. They are waiting to sort of show themselves. And places like the liver and the lung are really ripe and rich for tumors to grow, but it takes time for us to actually see those cells. And so the question is, does removing the primary and lymph node metastasis prevent distant metastasis? Probably not. I think in many cases that micrometastasis was actually present at the time of diagnosis, but we do have data that suggests that removing the primary tumor and the regional lymph nodes, even in the setting of distant metastasis, does increase overall survival. So there are some cases where we will consider doing that. Again, very cognizant of tumor grade and tumor differentiation as we make those decisions, because not everything's equal. But I think in a well-differentiated patient, even with metastatic disease, I think removing the tumor not only extends life, but often improves symptomatology as well. So in many of my patients, I will offer that surgery. And it also depends on the location of the tumor. Everybody's going to be much more excited about resecting a distal pancreas tumor that doesn't require biliary enteric anastomosis in the setting of liver metastases. But if it's in the head of the pancreas, removing the head of the pancreas, when you know that there's liver disease that's going to need additional treatments, it really complicates what you can do down the road for the liver. And so these decisions are very nuanced, and they sort of have to be made based on the individual patient and a lot of tumor characteristics that we can't quite answer in general.
Thank you for that. And of course, multidisciplinary care, right?
Absolutely.
Dr. Kataya, what treatment is available for stomach NETs besides just removing them when they appear?
Oh, that's a loaded question. I mean, so stomach neuroendocrine tumors come in different types. There's type 1, type 2, type 3, type 4. Type 4 sort of been more recently described. So, the type 1s and the type 2s, we tend to manage endoscopically. They have less risk of spreading. We used to sort of do antrectomies if we really couldn't get good control. People kept having more than 6 lesions, but that's kind of falling out of favor because of the morbidity. And I'm sort of encroaching into Dr. Clark's territory here. But and even with type 3, which is considered the more aggressive one, they usually are isolated. The gastrin levels, the hormone levels are normal in those patients. They tend to be a little bit higher grade. We used to just cut them all out. Now it's like, well, actually some of them can be managed endoscopically. We don't necessarily have to do major surgery. That's probably more of a Dr. Clark question, actually. I'm going to defer to her on the.
I was going to go ask Dr. Clark next.
So I'll tell you, this is actually a very complex decision tree. And we're actually working, so NANETS, which is a Neuroendocrine Association in the United States, is actually working with the gastroenterology group to come up with better evidence-based guidelines to help us figure out this disease. But as Dr. Oz mentioned, for type 1 and type 2, typically we do not offer surgical resection for those. Those typically are well managed with medical management as well as endoscopic management if needed. For small type 3s, I think there's now evidence that we can manage some of those endoscopically as well, especially as those techniques get a little bit more complex. I think the biggest question that we're still trying to figure out is what's the impact of regional lymph node dissection on those patients. And that's really what our ongoing project is looking at. So I think in general, if there's evidence of nodal metastasis, then, surgical resection for these type 3s are certainly what we would recommend. Again, as we discuss all of these things, it's sort of stratified by tumor grade and tumor differentiation. But there are, I think, increasingly more endoscopic options. Again, very important that you see someone at a institution that does quite a bit of these, and so knows when it's okay to do an endoscopic resection and when it's not.
Thank you for that. Some difficult questions. It's helpful to see.
They're all difficult, but we love it.
Yeah, I'm glad we have two hematologists here as well. There's a question about iron. So Dr. Vijay, we'll start with you. If iron levels drop to 15, should we supplement with iron tablets? Also, does cancer really love iron?
Well, our body loves iron. So cancer cells are unfortunately part of our body that are just different than normal cells. So they do, like we all, but I don't think there's data to say that taking iron will negatively impact your cancer. Their body, cancer cells are smart. They don't need you giving them stuff to grow. They can just find the stuff they need from wherever they want. Same with sugar, same with iron or whatever any element, any chemical we talk about. Coming back to the iron of 15, the iron level of 15 typically is below the level of normal range. Anything 20 to 150, there are different ranges of what normal is based on what lab you went to. But 15 is a little lower. I am minimalist in terms of medication. So if the person's hemoglobin is normal and there's no evidence of bleeding, I'm going to look for why the iron is low rather than just supplement somebody's iron. And if their hemoglobin is low, you have to take iron. If not, I typically just tell patients to eat more iron-rich foods, iron fish, like all these different things that we do, because iron pills are not easy to take. So I would definitely, seeing the doctor, talking about the different options. But if the low iron is actually affecting you physically in terms of hemoglobin, leg cramps, anything, you got to treat it. If it's not, then you can just replete it with more iron-rich foods. But I think it's very important to know why your iron is low. If your iron is low because you're losing blood somewhere, that's a bigger problem than just the iron being low.
Good point. Dr. Kataya, do you have anything to add to that?
I could spend an hour talking about iron. Like that. I will tell you that obviously iron is the only reason, the most important reason we need iron is because it gets incorporated into the hemoglobin molecule. So it's a way to produce red cells. The serum iron being low can be from many things, including inflammation, not just iron deficiency. I really look at everything together, the iron panel, the ferritin levels and the iron saturation. What you need to remember is that you only absorb 5% of the oral iron you're taking in by mouth. So iron absorption by mouth is quite poor, and it happens through your small bowel, your jejunum. So if somebody's removed part of your small bowel, you're not going to absorb iron. So there are times when it's appropriate for you to get intravenous iron, and the surgeons love when we replete iron and get the red cells up before they operate. That's usually, they prefer to sort of have a higher hemoglobin. So it's a very complicated discussion. You have to look at the whole iron panel. You have to see what's the best way of repeating it. And of course, the more iron you take in by mouth, the more constipation and nausea you have, right? So like ferrous sulfate has 65 milligrams, ferrous gluconate has 27 milligrams. You have to take iron on an empty stomach, half hour before you eat, so to absorb it well. It's very complicated. I mean, you really definitely need to talk to your hematologist about what your full panel is, what your red cells are doing, and whether or not it's inflammation driving it down or low iron and how to fix it. But I agree with Dr. Vijay that, it has nothing to do with feeding the cancer or not. If you need iron to boost your red cells, then go ahead and do what you have to do to get more energy.
Thank you for that. That's really helpful. And actually, along those lines, what supplements do you suggest we take? And Dr. Kataya, we can start with you, and then we can go to Dr. Clark and see if there's anything that you might recommend with surgery.
Supplements, you mean just in general?
In general.
I think if you're deficient in something, you should definitely be repleting it, right? We fix vitamin D, but I don't really know what we're fixing. We do it because maybe there's a risk of breast cancer with that. Maybe there's a risk of colon cancer if we don't fix it. Maybe it'll help your bones. If you're iron deficient, fix your iron. If you're B12 deficient, fix your B12 deficiency. Otherwise, if you eat a balanced diet, and a lot of things in the US are fortified with minerals and nutrients. So, there was a study done at Hopkins that multivitamins were a waste of money. I don't go pushing a lot of supplements on patients. I just tell them to eat like a balanced diet and, and get their levels checked if they're worried about something. If that's low, they can try to fix it.
Yeah, I don't take a multivitamin. or any supplement personally.
Thank you. Dr. Clark, this might come up with before or after surgery. What do you tell your patients?
So I tell patients that, I'm more than happy to work with supplements, but not all supplements are safe, and they're not always benign. And especially as we lead up to surgery, typically what we'll do is we'll go through so I don't recommend any supplements. So I'll say that. But if somebody's on supplements, what I'll do is I'll sit down and go through their list of supplements very carefully. And I will talk about which ones may impact surgery and should be stopped before surgery. And then some of them that just don't have any, if there's something that really has no science behind it, then I usually, will point that out. But there are a lot of supplements that actually can increase the risk of bleeding and also decrease wound healing. And so it's really important that you talk to your doctor about these things, and certainly your surgeon. My approach has always been that I want my patients to tell me everything, and I want them to tell me what supplements they're taking, because then we can really stay out of trouble in terms of complications. So I'm actually, I think, a little bit more open and welcoming, and I'll reach out to whoever is prescribing some of these medications if they have a naturalist that they're working with. And almost always we will work together collaboratively. I've had a few cases where that hasn't worked out. My focus is more on making sure that none of these supplements are impacting either their current treatment options and are not going to cause problems for surgery later on. In terms of iron, I'm a surgeon, so the whole iron thing comes to me through the lens of anemia almost always. And I commonly see that where people have had usually a undiagnosed small bowel neuroendocrine tumor, and they've been having sort of, chronic anemia for some time that's been masked or trying to be masked by chronic iron supplementation. And I usually tell patients that you probably won't need the iron supplementation after surgery, because once we get rid of the etiology of this chronic blood loss, those numbers will actually correct on their own.
Thank you for that. Yeah, it's a balance with all of the supplements and then also preventing issues. Dr. Clark, we talked about supplements and anemia. How common are digestion process changes following intestinal resection?
Very common for neuroendocrine patients. And I always actually counsel my patients. So there are a couple of things that will almost always sort of happen. Is one, we hear a lot about diarrhea postoperatively, and we'll talk about that. And I tell everybody to expect it. Typically in the average patient, if we're taking a significant amount of small intestine, if we're able to leave the ileocecal valve, which is the portion of the intestine that is a transition between the small intestine and colon, I usually tell most patients that we give it about a couple of weeks, 2 to 3 weeks, for us to get to their new normal. So I expect them to be some diarrhea postoperatively. Typically, that improves over the first 2 to 4 weeks. And then we'll get a really good idea of what the new baseline is going to be. We can try to modify some of that with medications, Imodium, lanreotide, if they have metastatic disease or evidence of carcinoid syndrome, et cetera. And that it's going to take some time for us to get to a new normal. We also work very closely with a dietitian who also follows our patients, and will measure different components of the stool to figure out what's driving some of this. For pancreatic neuroendocrine tumors, you can certainly have what's called exocrine insufficiency, which means that the enzymes that the pancreas normally makes to help us absorb food is significantly reduced because we're removing a part of the pancreas. And so those patients might actually need things like pancreatic enzymes in order to digest food and absorb normally, just because they're not making as much as they need. So I think the biggest thing is that certainly at our program, you'll have a longstanding relationship with a dietitian who also works in conjunction with myself. And together we come up with a plan and a prescription that we think is going to be best for the patient. We very carefully monitor weight gain, weight loss, stool elastase, and other things that can give us a clue about absorption. And then we titrate medications as needed.
Thank you for that. I know there's a lot involved in that. And, actually, as you bring up this issue with absorption, Dr. Kataya, I know you also talked about in your presentation, how would you treat quote unquote upset stomach from octreotide, and what is malabsorption?
I don't know. My experience with octreotide has been that it can cause a lot of gas pain. Sometimes it can cause some diarrhea. I mean, stomach upset can happen for many different reasons. You just have to sort of tease it out. Is it acid reflux? Is it, something related to the drug? If it's from the drug and it's pretty bad and you've tried some methicone, or you've tried things to help with gas, and God knows diarrhea is very complicated in endocrine patients and they're really not getting relief and they're miserable, then you can try to switch to a different somatostatin analog, or they might not be able to tolerate that drug. In terms of absorption, you have to watch for floating stools and weight loss and replace with Creon if that's the case, because that can happen on the somatostatin analogs. You have to watch the zinc levels, you have to watch the thyroid levels. So we kind of monitor different things to make sure the medication is not causing, other things that we have to account for. But other than that, sort of depends what you find in the blood work and what the patient reports to you.
Thank you for that. Dr. Vijay, speaking of somatostatin analogs, are there any other areas besides your buttocks to get your monthly injection?
Not so far. Okay, so currently the way all these drugs stand is 2 available options. Both have to be given either intramuscularly or deep subcutaneously. Trying to give an intramuscular shot in your arm, like an deltoid, is so much more painful, a bigger one, that you probably won't be able to lift your arm at all and will render you, not working or useless for a week after that. So I think buttocks is the safest place to give it, and something that's actually most appropriate for your quality of life, even though I know it's not the best. And there are things that are being done to improve that. There are new drugs that are coming out that are being studied right now. Oral alternatives right now, the way they are being studied is more for the short, as an alternative to the short acting. But who's to say that the next step is that hopefully we can use them for, these long acting uses too. And then there's a subcutaneous one, which is more of how people give themselves insulin, just under the skin. Those kinds of versions are coming up. They're all under study right now. We don't have them available. So at least for the near future, we are stuck with the pain in the behind.
Yeah, stay tuned. And this question came up: how do we learn and participate in upcoming clinical trials? Speaking of studies, Dr. Vijay.
Yeah, so it is a very exciting time to be practicing neuroendocrine tumors, because we are seeing the treatment options increase and the paradigms being changed right in front of our eyes, and that is very satisfying, and that is, gives us a lot of hope when we talk to our patients. I remember when I was a first-year fellow, we had everolimus, I think, was the only one drug we could try, or we used to do 5-FE-streptozotocin. CAP-10 study was actually ongoing at the time too. And it was from there, we've come such a long way. And that is I am not tooled. I'm little, but I'm not tooled. So a lot of has happened in the last 15 years for these tumors. And it's all because of patients. It's all because patients agreed to be part of these clinical trials and move this field forward. And we expect and we hope we can continue to do so. So if you're looking for clinical trials for neuroendocrine tumors, the best way would be you can reach out to Lisa. She probably knows all that are going on, or talk to your doctor. There's clinicaltrials.gov website. You can just type neuroendocrine in there, or your type of neuroendocrine. It will give you all the studies that are ongoing, and you can filter it by the area that you live in. But if you don't want to do that, patient advocates, your doctor, we all know about them very, pretty much what are the options that are available in your area for a clinical trial. And if there is a study, you should definitely look into it. There are studies for octreotide analogs. There are studies for newer drugs. There are studies of new PRRT compounds. There are studies, as Dr. Hope studied, that you're going to hear about, comparing PRRT to other standard options that we've been using to help us find which is the best one to give up front. So yes, we and we can only know all these questions if you help us, and that will be through trials. Thank you.
Yeah. And we often reach out to each other saying what's going on in your area and network as well. There were several questions around LungNets, and I know we are having a dedicated LungNet webinar with Dr. Pata in August, but we do want to get to at least one of these questions. Dr. Kutaya, what are the new treatments for LungNets?
Unfortunately for LungNets, there's somatostatin analog, which hasn't, really been studied in a good clinical trial, but we've done it because some patients have positive gallium scans, and so we take advantage of that. But the only drug that's really been approved is everolimus. So, there are other agents, cabozantinib or sorafenib, that are being studied in combination with immunotherapy. There's a cabozantinib Temodar trial going on right now for lung neuroendocrine tumors. So there's PRRT that's being studied down in Texas for lung neuroendocrine tumors. The thing that's challenging with lung neuroendocrine tumors is that a lot of them are not as gallium positive as the small bowel and the pancreatic ones. So that kind of makes that technology kind of limiting. But there are still ongoing studies looking at combining immunotherapy with targeted drugs and, looking at targeted drugs by themselves also to see whether or not we can get some ongoing responses. So we are looking into it, definitely.
Yeah, thank you for that. Dr. Clark, this is an interesting question because, of course, when people are going to have surgery, sometimes they have an echo and it might show some things. So this person said, I have an upcoming surgery of small bowel resection and cholecystectomy. A recent MRI of the heart has showed tricuspid pulmonic regurgitation. Is it okay for surgery?
So that answer, the question needs to be answered by a couple individuals. One would be a cardiologist. One would certainly be a high-risk anesthesiologist. And if you've been on any treatment prior to the surgery, so if you've been on any medications, or if you have distant metastasis, and this could be sort of related to your carcinoid disease, which doesn't sound like necessarily, then you could also see a cardio-oncologist, who is somebody who focuses on cardiac issues that result from either cancer treatments or a cancer state. So typically what would be done at my institution is you would see a high-risk anesthesiologist who would do an advanced cardiac workup with a cardiologist. And then together they would essentially then give you a risk assessment as to what your cardiac risk is for a general anesthetic for a surgery that's expected to last for a few hours. So in that case, we're talking about a 2.5 hour surgery. And I actually like the cardiac risk calculators because it actually not just gives you your own risk, but it gives you your risk in comparison to the general population. So people have a better understanding of, am I really high risk for a cardiac complication or not? And sometimes if there's something that needs to be intervened on, they can actually do that prior to surgery. So I can't tell you definitively that it's okay for you to have surgery, but hopefully I can tell you that you should be seen by at least a cardiologist or a high-risk anesthesiologist so that they can tell you what the risk is. And how bad that regurgitation is, because again, a small amount of regurgitation is probably fine. If it's something that's critical or severe, it may actually impact your risk of having a perioperative or a cardiac event around the time of surgery.
Yeah, thanks for explaining how you go about thinking about that. And Dr. Vijay, this is an interesting question as well. How do you treat NETs in the blood? And what is the best form of treatment for fast-growing NETs?
We probably mean when we talk about the neuroendocrine tumor encroaching into the bone marrow, like so that it actually takes up your space in the bone marrow and brings your blood counts down because there's not enough space for normal blood cells to grow in the marrow, or circulating tumors. I think that's what this question means, so I'm going to answer it that way. So typically when, unfortunately, neuroendocrine tumor cells love the bones for whatever reason. So they, just how it can go to the liver, it is very commonly seen that it goes to the bone. And with our newer and more fancy and more sensitive tests that we do, like the gallium dotatate scan or the copper dotatate scan, either of those scans, we're seeing more and more of these disease. And when it goes to the bones, it can also, find its way into the marrow where the new blood cells are made. And we see very often that patients with, neuroendocrine tumors tend to have lower blood counts due to treatment, but sometimes only because of their bone marrow being infiltrated by these cancer cells. The treatment of this is the same as it would be, like we just consider these very similar to if you had cancer in your liver, or because when we give, it has to be systemic, it has to be medical treatment. So something that goes through your blood vessels and goes through every part of your body. So it's going to affect your liver, it's going to affect your bone marrow, it's going to affect your lung, bones, everything at the same time. And those treatments, if they're effective, they're going to decrease this, infiltrative pattern in the bone and improve your blood counts. PRRT, actually, I just had a patient who had low blood counts to start with, and we were sort of nervous about PRRT, but it was all, we did a bone marrow biopsy, it was all cancer in the bone marrow, and we started PRRT, and their counts actually improved by the second, third, and fourth treatment. So it's not treated any differently than it would be for other areas. The only thing is it's a little more tricky because if your blood counts are low, sometimes it's very difficult to give systemic treatments because they also lower your blood counts. And if they get critically low, you are at the risk of infections. One thing I do want to add to the part about what Dr. Clark said about the valve regurgitation, I think it's important that whenever you go for surgery and you have neuroendocrine tumors, as a part of preoperative surgical workup, echocardiogram should be considered because this is a known complication of carcinoid, which can lead to these valve problems. And if you are getting your surgery at a center who are not accustomed to this, it's always good to know, right? As Dr. Clark mentioned, there's a whole paradigm of things we need to do if you have this problem. So you should always be screened for it before you do it.
Yeah, thank you. And speaking of what might happen, Dr. Clark, how does a carcinoid crisis happen, and is there any way to prevent it?
So patients that may not have true carcinoid crisis leading up to their surgery, but that have metastatic disease can actually have a carcinoid crisis during the operation. And so that's really, for me, manipulating the tumor in the process of taking it out, increasing the surge of hormones that are being seen in the bloodstream, and then basically then causing sort of a overwhelming carcinoid syndrome or crisis. So for my patients that have metastatic carcinoid syndrome, this is always in the back of my mind. It's always a possibility. And so an expert team is prepared for this actually possibility. And typically what we'll have is a number of medications that are either available in the operating room to get started in immediately if we see any signs that this is where we're going. In some patients, if they already have symptoms like, significant flushing, especially if they have it daily, I'll start that drip actually in the preoperative area and take them back to the operating room and keep them on the drip during the operation to try to mitigate the risk of them going into carcinoid crisis intraoperatively. But again, it's something that your surgeon needs to understand and be aware of. Your anesthesiologist needs to understand and be aware of. And it's always better to sort of ward it off rather than trying to treat it. So that's really my approach for it in the operating room. And then I'll leave Dr. Oz or Neera to talk a little bit more about carcinoid crisis in the medical setting.
Thank you. Dr. Kataya, what would you think about this? How does a carcinoid crisis happen?
The main thing I have to say is that, if you do have elevated 5-HIA levels and the diarrhea and the flushing that goes with it, which means that you have serotonin production that's out of control usually, that you do have to try to drive that down specifically to try to avoid the cardiac complications. So somebody should be monitoring that and treating you. And there's all kinds of things we can do. We can do the somatostatin analog to drive down the serotonin. We can do Zermello tablets. We can do subcutaneous octreotide injections. They don't all work perfectly. Nothing corrects them to 100%. Like to go from not making too much to like making nothing. There's a little, like everybody's different, but usually 3 to 4 time elevation in your serotonin levels are what causes damage to the heart. So that has to be something that's addressed. I know Dr. Pamia has done some studies for the surgeons in terms of what they can do to avoid carcinoid crisis. And unfortunately, there's not a great way to avoid it. You just have to have your anesthesiologist and your surgeon just be aware that it could happen and try to be very on top of your vitals. But we always try to give everything, whether it's octreotide infusions, octreotide depot. But, unfortunately, it's not something you can avoid or prevent very easily. Just be aware of it and manage the vitals, from my understanding.
Yeah, thank you for that. And along those lines of somatostatin analogs, Dr. Vijay, are there any clinical studies for patients who are foregoing somatostatin injections due to side effects? And if not, are there any planned?
So for patients who either progress on somatostatin analog or cannot tolerate, they are eligible for trials that come after it. So, for us, somebody not being able to take a medication or that medication is not working is the same thing. We cannot use that drug. So we have to look for other options. And then we look for options like, PRRT or anything else. Currently, the studies that are ongoing there's PRRT combination clinical trials. So you can do PRRT with another drug. Again, typically the way we give PRRT right now, we do use somatostatin analogs with it, as you may know. But the use is more theoretical rather than, it is being debated both ways. Some say it helps, some say it doesn't. And I think if someone's having a lot of side effects, I'm very comfortable skipping somatostatin analogs for that. And also, just talking about what those side effects are, as Dr. Kataya mentioned, there are some supportive things you can do to help patients with somatostatin analog side effects because it is a drug that does work for neuroendocrine tumors, and these drugs are don't cause long-term problems. They're annoying in the short term, but don't. Hence, if we can deliver it to the patients, we'd like to do it. But if not, you basically are. We call it that the patient, the cancer has progressed on somatostatin analog. Whether that progression be due to the cancer growing or the fact that I cannot give it to the patient, both for whatever reason, now you are eligible for doing whatever comes after that.
Great, thank you. I think we could talk for a long time. We're just going to end with this one last question. Dr. Kataya, when should one be tested for MEN and other genetic abnormalities?
Oh, gosh. Where's Dr. Del Rivero? No, I'm kidding. So I would say that, if there's a family history, that there should definitely trigger a test. And if there's parathyroid issues, pheochromocytoma, and pancreatic neuroendocrine tumors in that same individual, or sometimes the parathyroid things happen sort of early, when people are teenagers or in their early 20s. That should sort of trigger, anybody who's young should trigger genetic testing in general, but especially gastrinomas of the pancreas should trigger genetic testing. But yeah, it's family history, young age, and multiple neuroendocrine tumors in the same individual should definitely trigger genetic testing for me, just to sort of keep it simple.
Does anyone else have anything else to add?
Yeah, exactly. And that too, mostly for the pancreatic neuroendocrines. Small bowel and mid-gut neuroendocrine tumors are rarely genetic. There are some, but for the most part, they are not. So anybody who has a young patient with a pancreatic neuroendocrine tumor, I always send them for genetic testing. Yes, they may or may not have all these same parathyroid, pheochromo, kidneys. There's a VHL syndrome where there's pancreatic neuroendocrine and kidney cancer that comes with it. So there's a lot of different things that can happen, may or may not happen. MEN1 is one, but VHL is another type of hereditary syndrome which can lead to tuberous sclerosis. There's neurofibromatosis. So there's a ton of diseases which lead to neuroendocrine tumor, but typically for whatever reason it's the pancreas and not so much the midgut. So if someone has pancreatic neuroendocrine tumor and young at diagnosis, and even if you're not, you want to go meet a genetic counselor, it's worth it in my opinion.
I typically screen, and I say screen, basically every patient with PNETs for MEN1. And you can do it actually quite simply through already routine labs that are done. So everybody usually has a calcium reported as a part of their basic chemistry panel. And so for every PNET, that's the next thing I look at. I want to know what their calcium levels are. And if it's even remotely high, then I think I send them for testing. But it is always in the back of my mind for every person that's diagnosed with a neuroendocrine tumor. And the reason the calcium is so important is that the parathyroid typically will precede all the other syndromes that will present. And so if they haven't had prior parathyroid surgery and they have a normal calcium, it's unlikely that they're going to have MEN1. There are always going to be exceptions to the rule, but those people tend to be way, way younger on the spectrum. But we just actually diagnosed someone with MEN1 who came in with the pancreatic neuroendocrine tumors in her early 40s. And again, it was based on an elevated calcium that had been, slightly elevated for a long time. It wasn't 12, but it was like almost 11. And so they'd sort of been watching it for a while. And that person was an MEN1 patient.
Thank you for that. It's been a pleasure to talk to all four of you, Dr. Clark, Dr. Vijay, and Dr. Kataya. I'm going to welcome back Josh, who's going to finish the rest of the Q&A.
Thank you.
We're going to do the second half and welcome back everyone, and want to just actually start out with a PRT question, but also an information question. So this comes up all the time. I actually answered this in the podcast that was released earlier this week. The newest studies from Europe, this is probably a bigger topic, but why doesn't the US follow the same protocol in Europe for PRT, especially when they've been doing it for 20 years? So I'm going to take this for a second, and then I'm going to turn it over to you, Dr. Hope. But obviously, Europe's a big place, and many centers do many different things. And actually, the trial to which this is approved was a global trial for NETTER1 that was based off a European protocol. So I guess twofolds. Why do we seem to have this thing that there's only one protocol that's done in Europe? And better yet, how are we looking to improve the protocols that are happening for PRT?
Yeah, so, okay, that's a hard question. And I think as you just highlighted, so there isn't a European way, right? It's not like Europeans do it way X and Americans do it way Y, and we're not like X. I would say Europeans do it A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, and we do it like K. And the way that it's performed in the United States is probably similar to the most common ways that it's done in Europe. And as you said, is based upon the protocol in NETTER1. Now, there are some aspects of what's done in Europe, which is, I would say, more of an art form. And those things we would not be able to do in the US. One of those things would be to do what would be called tandem therapy, where you do Y90 labeled, SSTR targeted radioligand therapy in addition to lutetium or other radionuclides, which, in the US were in essence, obviously limited to the FDA approved agents. And hopefully, obviously in the future, that that will change. But I think there's other things that, as we start to think about how do we optimize PRRT moving forward, is to probably think about how we would want to adjust the number of cycles we give based on absorbed dose, so a dosimetry modulated type of approach. But that's actually not done in Europe. In Europe, there's a handful of trials that adjust dose based on absorbed dose to the kidney, but they don't really actually do, any sites really do outside of that one or two trials, a dose modulated approach. So frankly, the US is actually pretty similar to what goes on in Europe overall, with some variability around the margins in the European side. So I think, there will be changes over the next decade as the way we use PRRT, and hopefully more data. Hopefully we'll learn more with some dosimetry data that will be coming out in the next couple of years to help us understand dose response. But right now, this is where we are.
And I'll say this across the wide spectrum. Most trials that are available in the US are available in Europe and vice versa, not only in PRT, but in other things. So the question for Dr. Haley is how do we deal with some of this information where a set of patients think that something's available somewhere where it may not necessarily be true? How do we deal with this information gap?
Yeah, it's a difficult one. I think knowledge and discussion with the providers is key here. Working in Canada, we often have patients that get opinions in the United States with the perception that there are treatments available in the States that we don't have in Canada, and hence Canadians are not receiving as up-to-date care. And then the one thing I would say is, like in anything, neuroendocrine tumor treatment is individualized. So it's not about protocols in one place or the other. It's about protocols for the one person, discussing those on an individual basis upfront and openly with the different providers. And because something is not available doesn't mean that it would be better for one specific individual. Doesn't mean that it's missing. We have to look at the standard of cares and what the guidelines are, and then go from there. One thing I found interesting, at least in the Canadian healthcare system, is because it's all publicly funded, every treatment that we provide has to be approved by the provincial or federal bodies that regulate healthcare. And they do a very in-depth analysis for each of them. They look at the effectiveness of therapy, at the side effects for patients, at the cost effectiveness as well, before it can be funded and be available for people. And I think at the end of the day, it might be a frustrating process, but it is a fair process. And there's a lot going on out there. It doesn't mean that it's all good, doesn't mean it's all good for everybody. And at the end of the day, it's probably just an honest discussion to understand things. Because I can hear that if you get a no without further details, that can be frustrating and lead to mistrust or misunderstandings. So it's all about the discussion, I feel like.
This is one I want to throw out to all of you at one point, but I'll start with Dr. Oz here. Does pretreatment before liver embolization by CAP-10 or really the question of does any treatment really limit another treatment, whether you're having a liver embolization first, whether you take CAP-10 first, whether you have some type of surgical resection. But if we look at this, I think one of the things that patients really want to know is if they go down one path, will they be stopped from another? So why don't we take this from an IR perspective first and let you go for that. And then I'd love you the opinions of the rest of the panel as well.
Sure. Yeah, that's a great question. I think a very important question to answer because, whether one treatment impacts another is very important, as we've talked about previously, that, in the journey of a neuroendocrine cancer patient, you'll need multiple therapies, and you'll have multiple options. So speaking very specifically to IR or interventional radiology procedures, I think I discussed earlier that we have two main ways that we treat tumors, which is one is to put needles directly into it and either burn or freeze or do some other form of direct treatment versus embolization, which is through the arteries. And even embolization, we can do chemotherapy, we can do radiation, and we can do bland embolization. So we tend to choose, whenever we're treating patients with neuroendocrine cancer, the least invasive or the least damaging treatment. So if you only have a few tumors, we prefer to take a needle and put it directly in the tumor and burn it away or freeze it away. And that's called ablation, as I mentioned, because that has the least amount of sort of collateral damage. If you do need an embolization, we have now, for the most part, switched over to doing mainly what we call bland embolization, because that tends to have the least sort of collateral damage to the normal or background liver. The radiation, which we do sometimes we do now less often, because fortunately neuroendocrine cancer patients live long enough that the radiation can actually have toxic effects to the liver over time. And I think Dr. Clark touched nicely on any sort of radiation treatments to the liver can make a future surgery more difficult. So in general, those tend to be our two preferred treatments.
Dr. Hope, I just wanted to touch with you. We talk a lot about sequencing and should you do something before, PRT or after, and does, where do you fit in this?
I think the two main interplays with PRT and other treatments are the liver and the bone marrow, right? And so in the bone marrow, it's usually an interplay with chemotherapies. You're a pancreatic neuroendocrine tumor, and capecitabine temozolomide would be sort of a standard of care therapy. PRT and CAP-10 will injure the bone marrow. And so you may prevent or delay subsequent therapies with other treatments, and they'll interfere with one another on the bone marrow side of things. So that's the first thing when you're thinking about PRT that could cause some issues. Whether or not which one goes first, we frankly don't know. They're both very effective therapies in different ways. And there are definitely some patients who might benefit with one over the other, particularly in the PNET patient population. Those with very, very high uptake on their dotatate PET, for example, would be one where you might prefer PRT over CAP-10. I think the other side of it is the liver. And so, I think of each of these as like a resource, right? You as a patient have so much of this resource available for a total number of therapies, bone marrow and the liver. And in the liver, particularly in patients who have liver dominant disease, you have an interplay with liver-directed therapy. And different liver-directed therapies have different amounts of efficacy and toxicity to the liver. And so it's a weighing of that toxicity and efficacy and how you want to do that sequencing with PRT, et cetera. I think with liver-directed therapy, one of the things that we do a lot of, well, not a lot of, but we talk about a lot of it and do use is the idea of maybe debulking prior to PRT. If you have a large dominant lesion or something like that, you can use liver-directed therapy to take out that disease so that there's less tumor sink, which means that the radiation dose that we administer with PRT will go to the rest of the tumor sort of in a higher concentration, hopefully sort of increasing the efficacy of PRT. So there's some sequencing options there as well with liver-directed therapy. But that's sort of what I think of with those two main types of therapy and how they interplay with PRT in terms of sequencing and overlapping toxicities.
Dr. Halleck, do you want to add anything to that?
Yeah, maybe like two small things. The first one is preventing toxicity that would preclude future treatments is a key component, I think. The other thing is also thinking about sparing of therapies over time. Like, we don't want to use all the ammunitions that we have in the first few months after diagnosis and then be left with not much down the road. Like, I think we've talked about it a lot today. This is a chronic disease. People are going to live for years and live, very good lives with it, but we need to maintain the therapeutic options down the road. And there's a very thin line between wanting to be aggressive enough to get good control and being too aggressive in that we're using all that we have at the beginning and are left with not much later on. So you have to think about that. I think in that mindset, surgery really helps a lot, because if we do a good job with debulking at the beginning of a disease, and we can delay the need for other therapies for later on. And then I think that all of this highlights the fact that none of these decisions should be taken in isolation. They have to be made by an entire team. If you see only an interventional radiologist, you're more likely to be recommended embolization. If you see only a surgeon, you're more likely to be recommended surgery. If you see only a nuclear medicine doctor, you're likely recommended to have PRRT. We have to talk to each other to make those plans. In our center, patients cannot see an interventional radiologist if they are not referred by a surgeon or by an oncologist. They do not get on PRRT without a surgeon and a medical oncologist being on the tumor board that decides a PRRT is recommended. So it's really about the team that has to make that plan and that sequencing assessment.
Thank you very much for that. And actually, one of the next questions, I'd like information about managing the side effects of Lutathera. Is it more than just being tired for a couple of days? And Dr. Mabal, I'll get to you there in a second, but Dr. Halleck, the use of palliative care and symptom management to manage these things like fatigue and hair loss and other things. Do you want to comment a little bit on that? And Dr. Hope, maybe a little bit after that on any specific things that you from a nuclear medicine perspective add in as well.
Yeah, absolutely. I think there's different roles in symptom management, right? There's the acute symptom management. So sort of the adverse effects that you receive from having therapy immediately or the next few months. And there's like ongoing symptoms. Like I showed it in my presentation, but we know that neuroendocrine tumor patients, at least in Ontario, are reporting high burden of symptoms over 5 years after diagnosis, and we're not moving the needle there. So there are some ongoing symptoms and ongoing needs. And to do that, it's good to have somebody that can follow you longitudinally, like, from the beginning till the end. And that is years for patients that live with neuroendocrine tumors. And, surgeons want to help, oncologists want to help, everybody wants to help, but we're not specialists in that. And to that end, the palliative care physicians, I think, are wonderful and very helpful. Sadly, they come in short supply. So that's sort of one of the limitations in getting everybody to see palliative care. But what I would hope is that would be the number one limitation. In my experience with a lot of my patients, the limitation is they don't want to hear that they're, quote unquote, palliative, because that's not a good word. And going to palliative care doesn't mean that somebody is palliative. It just means that we want to help with symptoms. And that's where I found that quote by Lynn Gates was very, very powerful. Like palliative is about living and living your fullest life. And then the other piece, like with the acute symptoms that happen when you're receiving PRT or chemotherapy or immediately after liver embolization or surgery, like the specific doctors that administer those treatments can be most helpful with that. But longitudinal person of symptom management, that's a palliative care doctor. That's at least how I said. I wish we could get everybody on to see them.
And Dr. Hope, any tips or tricks either prior to PRT or after PRT to minimize the symptom burden?
Yeah, so with PRT, the way I usually tell a patient is the first cycle, you're going to learn how you do, right? So most patients, the first cycle is usually the worst experience for them, for whatever reason it may be. And so that is sort of where you learn if you're going to do really, I'd say over half the patients actually do pretty well. They have maybe a couple days of tiredness and some lethargy or loss of appetite, and it goes away on its own. But then there's like a quarter of patients who actually really struggle with PRT. Sometimes those are maybe older patients who have sort of less of a reserve, tolerate the treatment for whatever reason, or maybe heavily pretreated patients, though sometimes you can't really tell. And now in patients who don't tolerate as well, sometimes we give a steroid bolus, a pulse, a taper. 5 days of steroids sort of helps out with the energy, helps minimize some of those toxicities. Some patients with a lot of bulk of disease, particularly either in the liver or the mesenteric root, can have some issues. The mesenteric root being related to abdominal pain, maybe some venous ischemia, where when you eat you get some pain, or some ascites, something like that from the tumor swelling, which the steroids can help with. In the liver, the swelling of the tumors can cause some abdominal pain from the liver capsule, et cetera. It's very unusual to need pain medications, although maybe 1 in 20 or 1 in 30 patients maybe will ask for some pain medications for treatment. So mainly the symptom management is a use of the steroids, and it's pretty limited from the giving of drugs nowadays, now that we have compound amino acids.
Dr. Oz, there's a question of, can you do liver embolizations on like 3 large liver tumors, even when there might be 20 or so small liver lesions? In other words, can you do selective liver embolizations?
Yes, Josh, that's a great question. Absolutely, we can. If there is a specific indication to do that, like the concept of a liver debulking, or if those are the only lesions that are growing. And again, these decisions are made, in a multidisciplinary format with our surgeons and our medical oncologists. The way we do that is, again, the arteries anywhere in the body are just like, highways to different parts. So if we want to go into a specific tumor, there is going to be a specific branch or artery to that, which obviously is going to be a little bit more difficult or more challenging. But in general, we can get into almost any artery as long as it is bigger than 1 millimeter or so. So we can be far more selective, and we tend to be more selective in other cancers that we treat because those tend to be very focal in nature. So even if a patient has multiple and we want to target 1 or 2, we can do that.
Thank you so much for that answer. Dr. Hope, one of the questions I get often is, how small can we image something? Where's that line that you can see? And is there a specific type of imaging modality that does better with that?
That's a good question. So how small depends on lots of things. So it's not like 2 millimeters is the cutoff. Anything less than 2 you can't, and anything greater than 2 you can. And I'm talking about PET imaging here specifically. With a somatostatin receptor targeted PET. The detectability of a lesion is a function of a couple things. One's the size, but one of the more important aspects of it is the uptake of the radiopharmaceutical. So a lesion that expresses a large amount of the somatostatin receptor might be able to be seen even if it's a millimeter or smaller, even depending on the uptake. I don't usually like to think about a cutoff of a size in terms of detectability. The thing I would add, though, in general, is that in neuroendocrine tumors, unlike some other types of cancers, seeing micrometastases doesn't change typically the management of the outcome of a patient, if that makes sense. I think we mainly, in general, assume even in a NED patient, there's probably micrometastases somewhere, and it will start to grow at some point in time. And there's no evidence, and there's not even really a good reason to start intervening super early, right when you see that very small volume disease. So in neuroendocrine tumor, I would argue that somatostatin receptor PET, dotatate, DOTATOC PET, is great. It's a wonderful imaging agent, and it sees the disease we need to see in order to determine the management that's appropriate to the individual patient. And I'm not sure that improved imaging that would see even smaller sites of disease with more accuracy is going to have a significant impact on patient management and outcome.
Thank you so much for that, and that's really helpful, Dr. Halle and Dr. Hope. I'm going to give this last one to you, but actually anyone can chime in here. Who should we be following on Twitter?
Well, I was gonna say follow Josh Mailman and Tom Hope, but so beyond that, I think somebody that I found speaks a lot to both patient and physician issues and is very able to unite them is Mark Lewis. That a lot of people might know. So he's a Twitter superstar. I haven't met him in person. I'm still waiting for that. I'm going to be super starstruck probably. But he's a medical oncologist and also had neuroendocrine tumor himself and has even live tweeted his own surgery and recovery when he had a pancreaticoduodenectomy. So I think he's a key person for that. If you want to remain aware of the different trials and events in neuroendocrine tumors, following LACNETS is also very helpful. And then also a lot of societies that work with patient advocacy. So LACNETS obviously is one today. The Carcinoid Foundation also has weekly webinars where you can actually they're not really webinars, or Facebook Lives actually, where you can ask questions to specialists in neuroendocrine tumors. So I find that those can be very helpful. And then there's a number of experts in the field that I follow because I enjoy the back and forth discussion about complex issues or new data. So Dr. Clark, who is here today, is one of them. Dr. Alex Ganji from Cedars-Sinai as well. And then in medical oncology, Dr. Pamela Koons and Dr. Thor Afenersen are also really great follows.
With that, I want to thank all three of you for joining me and having this short but really wonderful Q&A session. And I'll let you get back to your day, and I'm going to turn it back over to our conference co-moderators and back to the studio.